our other therapist, who's also here talking, and you get to listen to me talk about shoulder pain tonight and kind of go through a couple different things. But I'm guessing since everybody is here joining this, most likely you all have shoulder pain. So hopefully tonight you kind of get to learn a little bit about what you can do and what the shoulder joint actually looks like and different functions and issues, and hopefully come away with a little bit more knowledge and some activities or exercises to help you stretch it out and make it feel a little bit better. We'll see.
And I am recording this. If anyone, it's on the speaker view, so if you're talking, it will show. If you prefer not to have your face on our video for the office, just go ahead and you can blank out your screen. But we're not going to use it for sale or anything, so it's not like this is going to be. But if you'd like to have a copy of it, I would be happy to email it to you. And you can send me an email at, I'll put in the chat room, jill@pt180.com.
Well, it looks like we have most of the people who signed up, I think, Jill.
Great.
So should we give it a go?
Just entered one more person. Let that come in and
Nice.
we'll be ready. Perfect.
Okay. Jill, are we still in hold mode here?
We are, but Evan's going to start right now. Go for it, Evan.
Oh,
All
okay.
right, I'll give it a go. This is my first Zoom class that I've actually kind of led, and so forgive me for any mishaps, and if you guys have any questions, let me know. So we'll just start from here. How do I advance? Let's see. Just gotta figure out how to move to the next slide, and that's our first technical difficulty. Speak up.
See if you just hit the down arrow.
Should be able to, yeah, use the arrow keys typically.
Yeah, that's what you would think.
Are you logged on? There you go.
Yeah, there we go. Okay. Alrighty, so we're going to talk about the shoulder and just some fun facts just to start us off. The shoulder joint has the widest range of motion of all the joints in the body. Pretty obvious, right? Like it goes all the way around, up, down, in and out. The knee only goes one way. So you've got a lot more opportunity for injury with this joint. About 6 million people a year seek medical care for shoulder problems, and it's actually the third most common musculoskeletal complaint in the US. So not surprising that so many people have issues. What we're going to talk about tonight, we're going to start out on a little bit of anatomy so everybody understands kind of the structure and muscles surrounding the joint. And then we're going to get into some common diagnoses and imaging options, and then kind of treatment, whether it be PT, acupuncture, surgery, and go from there. So just starting out with a little bit of anatomy, your shoulder blade consists of a lot of different moving pieces. You've got your scapula, you've got your clavicle. Are you guys able to see my pointer? Yeah.
Yeah.
Your clavicle, and then you've got your humerus here, and it all kind of just hangs out on your thoracic area with your rib cage here. So there's a lot going on, a lot of different bones. We're going to zoom in. We've got the scapula here on the right, your humerus over here on your left, so your arm bone. This is the glenoid, so this is part of your scapula. Your humerus sits within this little cup here. It is a very unstable joint. That glenoid is pretty shallow, and so that humerus can slide forward, backwards, and it really relies on the muscular components to keep it there. We do have ligaments and capsules that kind of surround that joint. But really, those are passive structures, so those really aren't going to do a whole bunch of stabilization for you. However, the rotator cuff, that's kind of going to be your shoulder stabilizers. The rotator cuff, when I first learned about it, I had no idea what it was, and I thought they called it the rotator cup, and now I know. It's the cuff, and it consists of 4 different muscles. You've got your supraspinatus, infraspinatus. Those are on the back side of your scapula, so those actually are kind of pointing away from you. Your subscapularis there on the right, this actually sits on your thoracic and your rib cage, so that's kind of facing forward, if that makes sense there. Teres minor is your 4th rotator cuff muscle here, and that kind of hangs out by your infraspinatus. So the shoulder joint, it's going to rely on the coordinated actions of all these muscles and other active elements, muscles around, to help stabilize this joint. So they're kind of the dynamic stabilizers, you could say, to help hold that humerus, this head here, in place in that glenoid, that shallow divoted area. Just some other surrounding musculature that we have. We've got the pecs, the pectoralis major, which is here in the front of your chest, the deltoid side of your shoulder there, and then coming underneath those muscles, we have the bicep. And I know you guys probably all know this, but it's just a good little refresher just to learn these muscles and kind of understand what surrounds the shoulder joint there and help stabilize. And Jill, if you have anything to add ever, please feel free to jump in. Okay. So these muscles, what do they do aside from stabilizing that joint? The rotator cuff muscles, so your subscapularis, that's going to be your internal rotator. So that motion is rotating in towards you. External rotation is rotating away from you. That's going to be your infraspinatus and teres minor. Abduction is this motion out to the side. So your arm comes out, and that's your supraspinatus. Your bicep, you all know that, kind of flexes your elbow, and especially when your palm is facing up. We get a whole lot more specified when we're facing down, different muscles we're not going to worry about right now. Those are the important ones. Shoulder range of motion, as I said, this joint moves in all sorts of different directions. So you've got flexion, which is just pure straight coming up in front of you. Abduction, straight off to the side there. Adduction, across, horizontal abduction, other way. And then external and internal, like I just mentioned. So the ones with the asterisks or stars there, those are actions of the rotator cuff muscles. Joint stability relies on 3 different components, and these are components that we just touched on. So the passive restraints, so that joint congruence, how the humerus sits in that glenoid cavity, and ligament stability. So just that surrounding capsule, those fibers that kind of go around that joint. Those don't do you much, they're passive again. And then the active is the important one, the rotator cuff musculature. And then putting it all together, you get that neuromuscular control, which is that coordinated action of the rotator cuff and the scapulothoracic muscles. And that's where it gets a little difficult and where people run into problems. A lot of people like to use their pecs and their biceps to make the shoulder move, whereas the shoulder should move from the rotator cuff muscles, kind of the posterior shoulder. So that's the hard part, and we'll talk about that. So we're going to go through some common conditions. Maybe you guys have run into a couple of these or have these going on, but I see a lot of tendinitis and hypermobility here in the clinic. I wrote a stat, it's about 85% of patients have tendinopathy or tendinitis, so we'll get into that. And impingement is another one that kind of runs with that, and that was about 74% of patients. And adhesive capsulitis, which is also known as frozen shoulder, I've got it down there on the list. That's a little less common, but it's about 2 to 15%, kind of a wide range, but we'll talk about that. So tendinitis, it is inflammation of a tendon, and the tendon is that flexible band of tissue that connects muscles to bones. So when the muscles contract, the force is transmitted into those tendons, which then goes into the bones and helps move that whole entire limb. So when the tendons become inflamed, that pulling action of the muscle is impaired and that movement becomes painful. So what's the difference too between tendinitis and tendinosis? I'm sure you guys have heard both those words thrown around. Tendinitis is kind of the acute inflammatory disorder. So in response to trauma or repetition, the body kind of produces that inflammation that will irritate that tendon. Whereas tendinosis is kind of more of a degenerative disorder. It's more chronic, and it's kind of the accumulation of microtrauma that then leads to degenerative changes in the tendon, which can lead to more pain and dysfunction. So this tendinitis here is a precursor to tendinosis. Hopefully that makes sense. If you guys have any questions, feel free to put it into the chat and we can get on that too. So causes of tendinitis, a lot of the time it's posturally related. Well, that can cause a decreased subacromial space, and that subacromial space is this area right here. How does that happen? Your rotator cuff isn't doing its job of holding that humerus within that glenoid, and so that the humerus kind of shifts up and decreases the space here, which pinches on this tendon and causes inflammation and pain. So this can happen from decreased neuromuscular control, and you know those muscles aren't coordinating very well. Typically, we see this with a lot of overhead activities because that humerus is raising up and pinching. And the symptoms you're gonna get shoulder pain, neck pain, you can get pain all the way into your scapula, and you'll have decreased range of motion. So if you bring your arm up over your head there, at some point in that range of motion, you'll have either pinching, pain, or just not be able to go any higher due to kind of that pain there. Okay. Rotator cuff tear is the next one we're going to talk about. This is kind of more, so we've got tendinitis. Rotator cuff tears, in my mind, are more of a tendinosis type deal where you've got that continued micro trauma of the tendon that's then going to lead to a loss of that muscular integrity, a tear, whether it be partial or complete. If it's partial, you're going to have pain and it's going to be weak. If it's a full tear, you've lost the ability to contract that muscle completely and you're not going to get any motion. And you're not going to have any pain because that muscle's not there to pull on any tendons or anything like that. So rotator cuff tears, like I said, they can be chronic from that repetitive tendinosis or tendinitis and impingement, or it can be an acute thing where you have like a sudden lifting, somebody hits it really hard and it just goes. Okay. Bursitis. Within that subacromial space, we have a little bursa, which is a fluid-filled sac that kind of helps the tendons move with decreased friction. So really helps those tendons glide smoothly. However, when we do have a bit of impingement or decreased space within that subacromial area, that bursa is going to swell up and then impinge even more on the tendons. And so with the bursitis here, we can have pain, obviously, tenderness, a little bit of redness, maybe some swelling and warmth. And the pain can kind of radiate out from the joint area, which is different from arthritic pain, which we'll talk about. That tends to be confined right to the joint itself. So pain with bursitis will increase with activity or pressure. All these you get pain so far is what I hope you're picking up. All right, bicep tendon tears. This is the rupture of your bicep tendon from either your shoulder up in here or your elbow. This, I don't know if anybody's heard of the Popeye, I forget what it's called. It's like Popeye something, but when you contract your bicep muscle, Popeye had like a really big bicep down kind of towards his elbow. And so if you rupture your bicep tendon, that's kind of what you'll see, because that muscle is just contracting in one spot. This is caused from excessive stress on the tendons that are going to exceed the tensile capacity. So that tendon is no longer able to hold what you're asking it to hold and ruptures, which does not feel good. Rotator cuff pathologies are extremely common with bicep tendon tears, which makes sense because as you get a rotator cuff pathology, such as impingement, tendinitis, anything like that, that's when you're tending to use your anterior chest and biceps more often. So this overuse of these areas are going to cause more stress and eventually either tear or just increased dysfunction. So symptoms with this, you can hear a pop resulting in weakness. You're going to have a hard time flexing your arm or going from palm down to palm up, which is an action of the biceps. Shoulder dislocations. There are two different kinds. So there's a subluxation and a dislocation. Subluxation is where it comes out of that glenoid cavity there, but is able to reduce spontaneously. So come back into where it should be. Doesn't completely leave either. It's just going out 25, 50, 75%, and then coming right back in. Dislocation is when it's completely out of the socket and it's not coming back in. You need help for that. Shoulder dislocations are caused by trauma. So if you get hit in the front or the back, and primarily instability. So if your muscles aren't working to stabilize that joint and keep it nice and protected and solid, it can happen more easily. Anterior dislocations are more common than posterior. It's because we use those chest muscles and the bicep and everything in the front way more than the back. And so everything's being pulled forward anyways. And so just a little extra tap can just pop it right forward. Pain is an obvious symptom for this. If you have a actual dislocation, you'll be unable to move that arm until it's reduced again. Labral tears, just a little more anatomy for you. The labrum is a fibrocartilage ring that sits around the shoulder socket to help provide stability to that humeral head, which is your arm. Because it's such an unstable joint, the labrum is just a little extra piece of stability to help kind of keep everything where it should be. So labral tears can be caused by trauma, repetitive use, shoulder dislocations. Again, if that shoulder pops forward, it can come back and kind of pull on that labrum, tear it a little bit. There are a couple different kinds of labral tears. You've got your slap lesions and your Bankart lesions. And so that just means that you're either tearing it on the front or the back or the inferior part. That just depends. But your symptoms, you're going to have a feeling of instability. When you move it, you might feel some clicking, popping, or catching, or just some diffuse pain. Adhesive capsulitis. This is what frozen shoulder is, and I'm sure everybody's heard of frozen shoulder. It is when your joint capsule becomes inflamed and stiff and develops adhesion. So you can see in this little picture here, it looks very unhappy. It's a process that restricts shoulder movement. So the cause, it's actually unknown, which is super interesting. There are a lot of different theories with it. Could be a systemic cause or response to trauma, something that happened in the past, but it's pretty typically, well, it's more common in 40-year-old females than anybody else. And so it can last about 1 to 2 years too, which is not cool. The symptoms, we've got stage 1, 3 different stages here. In stage 1, they call this the freezing stage. You're going to get pain at your end range of movement, and it's minimally restricted, but this is when it's freezing. So that joint capsule is becoming more and more inflamed and developing more adhesions in this stage. And so with that, you're going to get less and less movement. Stage 2 is called the frozen stage. Your pain is decreasing, but those adhesions have developed by this point, and you've got severely restricted range of motion. Stage 3 is thawing, where you've got decreasing pain, and that range of motion is slowly returning. And so, like I said, this can last a year to 2, and is not a fun one to get. But if you're not a 40-year-old female, then it's looking good for you. Arthritis pain. Arthritis is the inflammation of the joints in the body, and this is really common. It's from daily wear and tear in combination with various injuries sustained throughout life, and it's the most common cause of breakdown of healthy tissues. So excessive use, misalignment, different injuries, all these things can add up and kind of cause arthritic pain. The symptoms are going to be some deep, dull pain, really localized to the joint itself. You're going to have a little bit of limitation in your range of motion. Morning stiffness is very common. And sometimes you can get AC joint pain, which is that flat bone right on top of your shoulder. That's your acromioclavicular joint. And that's a common area for people to get a little bit of arthritic pain. So we can look at imaging to help us kind of decide what's going on. X-rays, these are a really common one that most doctors have people go do prior to any other sort of imaging. X-rays just give us a bony look at what's going on in the joint. They can rule out fractures of the area, so you can check out, this is the humerus here. Here's that glenoid that we were talking about earlier. And here is a good picture of that AC or acromioclavicular joint where arthritis can sometimes happen, right in this area here. Another option for imaging are MRIs. MRIs are usually followed by X-rays if a problem hasn't been spotted, just to get a little more in-depth view of it. So you can find arthritis, bone tumors, worn out cartilage, ligaments. You can look at the muscles to see if there's a torn ligament or muscle or tendon, an infection. You can even check out the labrum, which is really cool. So here's a picture of an MRI. It's that humeral head right here in the glenoid. And then right in here is that joint space between the two. Here is the, so that might be the supraspinatus, some muscle of the rotator cuff. And here's where we see that rotator cuff tear. So these are really helpful in truly diagnosing and having 100% guarantee at what you're looking at. Injections are an option for shoulder pain. Corticosteroid injections are a common one. They're used to treat conditions such as bursitis, tendinitis or shoulder impingement, and arthritis, and they kind of help decrease inflammation. I think they last, it depends, a couple weeks to a month or 2. Intra-articular steroid injections and injections into bursa are just other options that both help with decreasing inflammation. So the intra-articular steroid injections, those are given into the joint cavity, so within the capsule right down into that joint. So you can get it in your knee, shoulder, your sacroiliac or SI joints, any joints in there. And then the bursa injections, those are used for that bursitis type pathology, which is that fluid-filled sac that kind of gets inflamed when things are rubbing over it and putting pressure on it. So that shot is going to help reduce pain specifically to that. There are different medications we can take, anti-inflammatory meds like ibuprofen or naproxen. And then we've got homeopathic options like arnica, which I found to be really helpful with people. Just a nice cream you can put on and helps decrease a little bit of pain there. Also got a couple other options. And really a simple one that people miss are just heating or icing. I think heat's a very popular one. Ice is good for inflammation. If it's more in the acute stage, I think ice is really important. Acute stage I like to think of as 24 to 48 hours or 0 to 48 hours. After that, something becomes a little more, persistent and chronic. I think that heat is really a beneficial option. And really, I'm not going to be picky either. If you like heat or ice, whichever one you prefer, if it feels good to you and you feel like it's helping, go for it. Acupuncture is another really great option. Acupuncture helps relieve pain, reduce inflammation, releases tight muscles, and can help increase range of motion for a variety of shoulder problems, neck problems, really anywhere in the body. I think if you haven't tried it, it's a really great thing to try. So now we're going to get down and dirty with the physical therapy. Manual therapy is something that Jill and I both do a lot in. Jill's very specialized and I've been trying to learn from her. And so this is the hands-on approach where we kind of help release muscles, work on joint hypomobility, and try to get your body to be in a more aligned what do I say? Just more aligned and better posture so that we can help you move more efficiently and teach you how to exercise for that mobility, stability, and strength in a manner that's going to be way more effective. Postural training is another thing that is super important and is something that I think PTs and just people in general should focus on every single day, because I think posture is kind of something that's going to cause you lots of problems if you don't do it right. Modalities are another option that we can talk about here in a bit. So, not sure who's all been to PT before, but just wanted to give you a little look at what a PT evaluation actually looks like. When you come in, we do a look at your symptoms and your history. And that just gives us an idea of what we need to look at, what we think is going on. So then we can look at your range of motion, your muscle strength, your movement patterns, and special testing to help determine your limitations and what exactly we think that we need to address. So some common things that we do find in these evaluations are poor posture, which contributes to that anterior chest and neck tightness, stiffness or hypomobility in your back and ribs, which are contributing to your shoulder having to work harder, which is going to cause you more pain and dysfunction in the end. The last one is weakness, and that's just going to result in poor movement patterns. And really, it's a cycle. That poor posture leads to muscle tightness, which then leads to instability and inability to move through certain areas, which causes joint stiffness, and then more weakness, more loss of range of motion. And then it just continues because we don't fix anything. So, postural influences on the shoulder. On the left, we've got really, really terrible posture. And I hope none of you have this posture or none of you have this posture. And we're all right here. We're just right up and down. Our ear is aligned with our shoulder, which is aligned with our hip, which is right down through the middle of our foot here. In these pictures, the left and right, we've got a very forward rounded shoulder here. So with that, our anterior chest is getting really tight, and the back of the shoulder here, all those muscles are being stretched and pulled forward, which is going to kind of inhibit their ability to work, and it's going to cause you pain. This guy, I'm sure, has a lot of neck and back and knee and hip pain and everything going on right here. So, all right. So I'll give you guys some exercises and options to work on posture and kind of the strengthening, and we're just going to go through a lot of them. These are two options to help open up the front of your chest. This one here on the left is a pec stretch. Just putting an arm right up on that door, staggering your stance, and kind of leaning into it a little bit just helps stretch out the front of that chest. If anybody has a foam pad, this is a really good one, or a foam roll. It helps open up that chest as well. More posture things. If we sit at a desk all day long, we kind of tend to curl forward, again, tightening that anterior chest. So just a nice thing to do. Arms out in front of you, rotate them out, and that's just gonna help kind of turn on the back of that shoulder and stretch out the front of that chest. You can add a band into it if it feels too easy for you, but if you're just at work, feel free to just kind of rotate open 10, 15 times, and that's all you need to do. Postural support. So at night, if anybody's having pain while sleeping, supporting the arm is actually going to take away a lot of that pain because those muscles are going to get a chance to turn off and relax. So just hugging a pillow is going to help shut everything down. And don't sleep on that shoulder either. If you're having shoulder pain on your left side, try to not sleep on that side. Sleep on your back, sleep on your right side. Just try to avoid putting that pressure on it because it's just going to pull it more forward. Body pillows are great too. Supported sitting is great. If you could get some pillows and put it under your arms. If anybody's in a chair right now and you've got pillows around you, go ahead and just put them under your elbows and just feel that shoulder kind of relax into it. It's really going to take off a lot of strain and stress on that shoulder. Thought I would include this just because we're all, or a lot of us are working from home right now, or just kind of a good little image on what your posture at your desk should look like. Your arms, your elbows should be supported, like I kind of just went over there, at a 90 to 110 degree angle. You should have some lumbar support. Can't really see his, oh boy, we're getting ahead of ourselves here. Hips should be above your knees just slightly. This one's a little bad. He could be a little more elevated here, but you want your hips above your knees just so that you can have a bit more support into your legs, which is going to take a little bit more weight off your lumbar spine and your butt. And then put that weight in your legs, let those do some work. And I won't get any more into that because we're not going to talk about knees or legs or backs or anything. So. PCO taping. Taping is another good option. Taping is great because it gives you a little bit of a postural reminder. So if you feel your shoulder coming forward, that tape's going to pull on you a little bit and be like, oh, nope, I need to pull those shoulders back. No slacking with my posture here. This is kind of just an option, like I said, as a reminder, and it's not going to be an active fix for you. All right, we're going to talk about mobility a little bit. Stretching is great. This is a really good exercise. I'd prefer you to do it at a sink so you can kind of give a little bit of distraction and kind of pull back from the sink a little bit. This is kind of working on thoracic mobility here. Obviously, you get that shoulder flexion, and it feels really, really good just to kind of give that shoulder a little bit of a pull. The book exercise. Thoracic rotation is what this is. This is one of our favorite activities here at PT 180. This is really going to open up the front of that chest, kind of work on the rotation of your thoracic spine, which is going to be really important for that scapulothoracic shoulder mobility there. And so you can do this stretch here. You can hold it out and kind of rest in this position and breathe through it for 15, 30 seconds, however long you want to be there. Or you can kind of open and close it, depending on what feels good to you. But if I had to say one takeaway stretch, this would be a really good one for everyone to try. Neck mobility. The neck muscles get overused a lot when we have shoulder dysfunction, and they start to get really tight, which pulls that shoulder closer and closer to your ear, which is not going to be helpful for you. So I thought I'd include a little neck stretch. If you guys have a belt at home, you can always use that. And that's just helping lock down that shoulder so that when you go to stretch your neck, you're actually getting a good muscle stretch there. So I like to do 3 different parts. You can lock that shoulder down with that belt and then bring your ear away from you towards your shoulder. And then from there, you're going to rotate your head down to look at your shoulder, or sorry, armpit. And from there, looking up over your shoulder. So holding each of those positions about 30 seconds will help you get like a full good stretch and kind of help release those neck muscles. Okay, we're gonna get into strengthening options a little bit here. I wanted to include, these are easy isometric activities. Isometric meaning you are just holding that contraction. You're not actively moving back and forth. You're just stabilizing there. So these are good ones just to help get the muscles around the shoulder activated and stabilizing that glenohumeral joint there. The first one I've included is external rotation. So it's that picture on the left. And you are just kind of pushing that back of the wrist out into the ball and holding. So with all these exercises too, it's going to be really important that you focus on what your shoulder up here is doing. Set that shoulder back, pull it back, set it down, and don't let it pop forward or rotate from your shoulder. Your shoulder should stay stable and it shouldn't be moving while you do these exercises. You should just feel those muscles working. Abduction is a different motion. I put these next to each other because they get mixed up a lot. This external rotation, you're rotating that arm out, and abduction is you're trying to bring that arm up away from you. Internal rotation, another rotator cuff movement here. Just being in a doorway and kind of pushing into that door. Protraction. That's a scapular movement for sure. This is a really good one. A lot of people use their pecs or their anterior chest to protract or move that arm forward. This should feel like you're coming or you're getting that movement from your shoulder blade. You're kind of going to lead with that pinky and you're going to pull that shoulder down and push it forward into that wall. You can keep a hand on your pec muscle and try to play with it to try to keep that muscle nice and relaxed as you punch forward. And it'll take a few tries. I think this is one of the harder motions to learn, but it's one of the most important ones. Extension, this is a good one. Pushing that elbow into the ball or the wall there, making sure that shoulder's not rolling forward or you're not arching through your back either to get the motion. Mention, keep that shoulder stable. But with all these two, core is super important. So you get to focus on that as well. Keep that core nice and tight. A different one here, we've got bilateral external rotation, and this is an isometric. So if you guys have bands at home, I wanted to include a couple of these. Just pulling out on that band, holding those shoulders down, and holding that for about 15 to 30 seconds, whatever you're able to do comfortably. That gets both rotator cuff muscles working there and that posterior shoulder and helps open up the chest. More band options here. Scaption is kind of the movement. It's 30 degrees out to your side, 30 to 45, and it's just lifting up in that plane, and that's kind of the ideal position for part of your rotator cuff muscle to work in. So if you kind of step on a TheraBand there, hold that band out, thumb is pointing up, and you've got your shoulder blades together, shoulders are relaxed, your upper trap and neck muscles aren't working, and you're just pulling up from that shoulder and back down. Shoulder extension. So if you could put the band in your door handle, close the door, hopefully it doesn't snap back at you. And then keeping those arms straight, just pulling them right down to about where your hips are. You don't need to go any further back. and then slowly releasing it back up to where she's got it. A lot of this motion, it is coming from, yes, your shoulder extensors, but also I want you to feel like you're squeezing your shoulder blades together as you do this. You want to work those scapular retractors, as they call it, and kind of help bring those shoulder blades together and then slowly release them apart. Rows. Same thing with this, just bent elbows. And I want you to pull those shoulder blades together and then slowly release it. This is a very small motion too. You're not going to be bringing your elbows all the way out into this area and then all the way back into here. You're going about here to here. Very little, just pulling the shoulder blades together. Couple different, a few more rotator cuff strengthening options with the band. These are more the active ones. So we had the isometrics, which is just holding, and now these are more concentric, eccentric, whereas you're contracting and then slowly releasing. Slightly different motion. So you can see here, she keeps her elbow on her side and just rotating that arm out a little bit and then slowly bringing it back. This is going to help get that posterior shoulder. And the other way. You can't neglect one of the muscles of the rotator, so you got to do the other. Internal rotation. Abduction here. You can bring your elbow off your side. And those are all my activities. I just wanted to touch briefly on surgical options. Surgery is kind of tough to recover from with the shoulder. They're difficult, and there's a long recovery period where you have to keep it stabilized. Then you slowly start having somebody else like a PT move it for you. And you have to slowly move into active range of motion or assisted and kind of work through all these different steps, which it works great. But I think that conservative treatment is definitely the first option that anybody should have prior to going to surgery. Surgery should always be your last and final option. But if you have questions about surgery or think that you need it, you can always talk to us about it first. So that is all I have. And I wanted to let you guys know that if you wanted to come in and talk more about your specific shoulder problem, I would love to have a little discussion with you and try to figure out whether PT is a good fit for you and whether I think if I can help you kind of decrease your pain or anything. So if you have any questions, right now I would love to answer any and hopefully get to see you guys at some point. So I'll open the floor if anybody has anything. If not, thank you for coming and listening to me blabber on about the shoulder, and I hope you learned something.
One of the things I wanted to say, Evan, because a lot of people immediately, if they find out they have even a partial rotator cuff tear, the immediate response is, I have to have surgery. Mm-hmm. And statistically, what they look in the research is if the tear is less than 50%, you have a very good chance of rehabbing it with conservative care with no surgery. If it's more than a 50% tear, the studies show that within 2 years it will probably rupture. So you can kind of keep that in mind on the severity. If, you know, in the MRI picture that you showed looked like it was an 85% tear. And that is not going to fix with conservative treatment. So it's important to actually get that kind of information from your diagnostic testing to see where you sit. Because if it's a mild tear, it will rehab itself with the right things. And just in expounding on her exercises she's gone through, none of those exercises should be painful. Mm-hmm. You know, if you're trying to do that trunk rotation exercise and it really hurts your shoulder, do not push through that. Or if you're doing some isometrics and it really hurts, don't push through that. You really want to have, if it hurts, there's usually something that's wrong, either with your technique, that neuromuscular control, you're firing the wrong muscle, you're doing the wrong sequence. So I think doctors Okay, I know doctors think they can give you handouts and you'll be fine, which is a little bit of a problem with this Zoom call, because you think, oh, I have these exercises, I can do it. And we are creatures of habit. And if we've had a bad shoulder, there's usually a pattern that we have done over the years that we will continue to try to perpetuate during the exercises. So if there's discomfort or pain while you do it, you can say, oh, my form's bad. I'll have to go to find somebody else to show me how to do this right. But it's important to get professional help on that so you can actually do it correctly and make sure you're actually learning a new correct pattern instead of repeating your old one.
All
Will we
the
be
time
able
people-
to get a, oh, excuse me, would we be able to get a copy of these exercises?
Yes, in the chat, I put my email there.
Okay,
Email me directly and I will send you a copy of this.
okay, thank you.
You're
I have a
welcome.
question. Can you hear me?
Yes, Stephen.
Okay. So we bought a rowing machine, which I've always enjoyed those in the years before at the gym. So I got a rowing machine and then I probably was at a lighter level, but I quickly went up to a pretty heavy level so that I could get a full workout in 5 minutes, huffing and puffing. And then both of my shoulders started hurting right up in here. So I thought, well, I better stop this. Usually when I get pain, it means I need to stop something. But so it's probably been about 3 weeks I've stopped and I still have the pain on both shoulders. And it does help. The hot tub does help it a little bit, but nothing's really made it go away. So I'm hesitant to do any kind of exercising with my shoulder right now because of that. Now that sounds to me almost like an inflammation or something that I've done to my shoulder, but can you really speak to that on a Zoom call? What do you think?
Go ahead, Evan.
My guess is that there's probably some sort of movement that you're doing there that is inflaming that. Yeah, hard to speak about it on a Zoom call, but I think that what you're doing where you're stopping and calling it good when you start to feel that is a good thing to be doing.
Yeah.
Do you have anything to add on that?
Do you think I could exercise my way out of this pain, or do I need to? I mean, I'm guessing I need to not do anything for a while, but at some point I want to get started again. So,
Well, the problem is if you rest too long, you're just getting weaker. So, and possibly tighter, which would be interesting to see how your shoulder blade is sitting. It's rowing typically when I see muscle substitution with rowing, it is usually the pattern that Evan was talking about, which is too much of the forward shoulder, bicep pec emphasis. And you may be doing more elbow flexion, pulling your arms to your shoulders
yes,
rather than retracting your shoulder blades back.
right.
And it's a mechanical issue. So that's that whole sequencing.
Mhm.
You've been doing that for a long time. That muscle may be too tight.
Yeah,
Need to get loosened
yeah,
up.
just got started. So
Yeah, well, but
probably about a dozen times on the rowing machine, and then I got up to where I was really pushing it, which you always think that's
And you
gonna
just
get better.
overdid.
And
yeah, a lot of us though, because if we sit too much, we're at a computer too much, we have a little bit of tightness anyway, so we're kind of susceptible to it, and that may have just pushed you over the edge.
right, right.
It would, that would be a great thing to come in for a 15-minute free consult and have Evan look at you.
And give you some mechanic options. Mhm.
Sure, I think that's a great idea. Thanks.
Mhm.
I have a question. I didn't have shoulder pain until I got a job where I was doing repetitive motion, and I cannot stop doing that repetitive motion because I do that for a living. Do you have any suggestions about what to do if you have to continually use that shoulder?
What motion are you doing that's repetitive?
Well, it's
don't mind.
the motion is putting my arm up. It's like putting beer into cases, and it's for many hours at a time. But after I do it, I mean, my shoulder hurts all the time now. It's been about 1.5 years, but it never hurted before I started doing this. So the motion is lifting up the shoulder and putting the hand down. So you're lifting up so the elbow's pointing out, putting the hand down.
Yeah,
So
so a lot of the time with that, that's sort of the impingement case. So you're decreasing most likely that subacromial space that I was talking about.
mhm.
It's squishing those tendons, which is going to cause a little bit of inflammation. And that's a repetitive thing. You know, when you in that, it's going to start getting more and more inflamed and start hurting every time you do that motion.
Yeah.
That's hard. I mean, you can't stop using it, right? And so it's kind of, you've got to focus as you're reaching up. It's kind of hard to show here, but as you're reaching up, try to pull that shoulder blade down.
Okay.
Letting it climb up towards your ear, just a tip. Maybe that's something you're doing. And try to push forward with that shoulder blade rather than using the front of your chest. I mean, I'd have to see what you're doing, but
Yeah.
little tips to try. Jill, any thoughts on that?
Well, and the other issue with that, Lori, is if you've done a pattern for a long time and you want to, that's where kinesio tape can be really, really helpful in teaching how to do it. And you can leave kinesio tape on for a week. So if you could get the shoulder so it's in good position and tape it, tape would stabilize it for you. And it's amazing when you put tape on someone, they go, that's where my shoulder is supposed to be? Never been there. Because again, we do things repetitively the way we just have done them. And when we stress them with repetitive movements or loaded movements and weight is when we get into trouble because they really aren't efficient. Most of us aren't efficient. You know, normal is dysfunctional. So to avoid pain, you actually want to get to be efficient, which is special. You have to be really good at things. And there may be some rotator cuff weakness that's not controlling that movement enough. Shoulder extension, rotation, and abduction is classically weak on people, especially women. Most of us have not done a lot of shoulder work. And
yeah, I have.
so, but when you're lifting, again, kind of what I had mentioned to Stephen is that bicep and that pec may be your dominant muscle because they're stronger. The rotator cuff muscles might be a little wimpy. And so they're not holding that shoulder correctly. So it may be something of just, again, getting that motion back, getting that correct postural position, maybe some taping, and then having a little home program for some strengthening that you do a couple times a week.
Yeah, that's awesome. Thank you very much.
I have a question, Jill.
Yeah.
Or Evan. You mentioned that if it was less than 50% tear, I don't have results of my MRI yet, so I don't know my percentage, but that you could rehabilitate it with what do you call it, conservative treatment as opposed to surgery. When you rehabilitate it, does it actually grow a tendon back to its original cross section or strengthen what's left? How does that work?
It actually scars and thickens. So the body can do quite a bit of self-healing. It's kind of like a bone would heal if it were a fracture. It will actually, there is a law called Wolff's Law, and tendons will actually heal in the direction that we put forces on them. So we want to make sure we're doing correct forces so the tendon can actually get a little thicker and stronger because of the exercises that you do. But again, efficient positioning and good movement patterns and full mobility. So their strength is actually one of the later things to come because you don't want to be strengthening if you're in a really bad position and in pain. You want to make sure that we get that shoulder girdle sitting correctly. And that's where manual therapy or stretching can be important, and posture education. So all those things are components that you want to look at. And we want to prevent having more injury as well. Because if you continue the same pattern, you're probably going to go down the same road and actually have more trauma to it. And people will say, well, I've rested it for a while, but if we still are in the same posture pattern and still doing the same lifting pattern, you're going to still have injury. So we want to correct all those issues. Does that make sense? And I can probably give you some good PTs in Kansas.
Oh, thanks.
Let me know.
Hey, Evan, thanks for a great presentation. Jill, thanks. Thanks for bringing a topic to my, or top of mind anyway. For the last 3-4 months, I've had a pretty nasty pain, originating from tricep all the way up to my upper neck. I have a fairly good suspicion as to what might have caused it, but I think it's a combination of things, mostly stopping summer exercise, daily exercise, being on the computer longer days, and stopping yoga. Blame COVID for all of the above. But I think I'll just have to come in and make an appointment and have you take a look at it, because it's been, I just checked my calendar since late October, mid to
No,
late
that's a
October.
long time.
That's what I usually push through these things, and because I exercise a fair bit, whatever, it'll go away. But 3 to 4 months is with no significant improvement. I can feel it throbbing, and I can feel it during sleep, throughout the night. So it's not great. And what really, like the shoulder press movement, really aggravates it, which is
We're
part of
obviously getting some impingement with that.
yeah. So I think it's not something that's going to fix itself after 4 months.
Well, and that's kind of a train of thought. Typically, inflammation usually goes away within 2 to 5 weeks if things are actually rehabbing correctly. So if things are lingering really much more than 5-6 weeks, it's really important to see somebody. And I think, especially if you've been active and you're relatively healthy, we ignore little inconveniences going, well, it'll get better. But the problem with shoulders is if they're not really getting better, they're actually getting worse. So you want to actually, yes, look at it and have somebody check up.
Yeah. Does not sound fun, so.
No.
Yeah.
No, and yesterday I had a pretty hard crash at Bogus on the other shoulder. I was like, oh, that's just what I need.
Those shoulders, yeah, great.
Yeah, you need one good one at least.
Appreciate it. I'll email you.
That'd be great.
Perfect. Any other questions? Awesome.
Great.
Well, thank you very much, Evan. I appreciate the PowerPoint. It was great. I love your cartoon.
Yeah, thanks for listening to me blab on about it. I appreciate everybody. Thank you.
Yes, thank you both. It was very helpful for me to hear the different parts of the shoulder and how it works. And us guys that fall down at Bogus and overexercise need to pay attention.